Hello, good evening, ladies and gentlemen. Thank you very much for coming out on what I think is probably one of the coldest nights so far this year. I hope you got here all right, found some parking, and there's tea and coffee at the end to keep you warm, and I think biscuits as well, so do help yourself to those. My name is Gail Downey. I'm a journalist and filmmaker. I do not work for the NHS. I've been asked to chair a number of public consultations as an independent person who knows Oxfordshire well. I've lived and worked in Oxfordshire for a number of years. A couple of points, housekeeping points. First of all, we have to do the obligatory fire exits, which are obviously incredibly important. The doors are here, marked, should anything dreadful happen. The toilets, if you don't know, they're out of here and turn right. Both are yellow doors marked, ladies and gentlemen. Hearing loop. If anyone needs one, is anyone okay for hearing loops? That's fine. And we're making sure that works. If there's any issue at all, let us know during the meeting. And we've got technical people on hand here who will be able to help you. The audio, so the sound of this public consultation is being recorded. There's no video, just the sound of it is being recorded. So if you wanted to hear it back later, you are able to do so. If you will be kind enough to put your hands up when you want to ask a question, we have volunteers here tonight who'll be going around with roving microphones like this one, and they will come to you. Give them a moment to get to you and then ask your question, please, to the panel here. If you don't feel that you want to put your hand up, but you'd like to do a written question, they've also got postcards and pens, which should be on the table. If not, they'll bring them to you. And you can write your question, and those will be read out. If we don't get to all the written questions, we'll put the most frequently asked questions on the website with the answers. So that's a bit of the housekeeping. Just to give you a running order of how it's going to go, we're going to have the panel introduce themselves so you know who's answering the questions you're asking. And a short presentation is going to take place, which will tell you the background of why these proposals are taking place. There'll be a Q&A, question and answer to the panel for about 20 minutes, and then we'll crack on, get to your tables where there are representatives who you can ask the questions to face. So I would suggest the kind of more details or any specifics hold for the round table where you've got people there that can probably go into more detail, the more general questions. But it's your consultation. It's completely up to you. I'm just here to make sure you get your questions across to the panel who've taken time out to come here. So let's start with introductions, and we'll start with Catherine at the end, please.
All right, so I'm Catherine Mountford. I'm one of the directors of the Clinical Commissioning Group, and I lived in Oxford for over 18 years with my family and worked in the health services here for all that time.
Hi, I'm David Chapman. I'm a GP in Oxford City in Holloway Medical Centre. I'm also the locality director for Oxford City for the CCG.
Good evening. I'm Tony Barrett. I'm the medical director for Oxford University Hospitals Foundation Trust. I'm the board lead for quality, so all things related to quality of our services. As an Oxfordshire resident, I came here in 1980 as a medical student. I've had my family here, lived here ever since.
Good evening. I'm Andrew Stevens. I work for the Oxford University Hospitals Trust as well. I've worked in the NHS for 34 years. I moved to Oxford with my wife, who's a teacher locally, about 20 years ago, and I've been in my current post about 17 years. So my job as Director of Strategy and Planning is working with our clinical colleagues, doctors, nurses, and the other organisations with whom we partner to plan services for the populations that we serve.
Thank you very much. And if we can start with the presentation, I'll just hand the microphone over to Catherine Mountford first of all.
Thank you. So I'm going to give a brief introduction as to why we're here, and then Dr. Chapman will talk about some of the clinical areas. So we're undertaking a lot of work around what should the health services, health and care services in Oxfordshire look like, doing a lot of work, and there will be other areas that we'll need to consult on, but we need to do more work. So this is our first phase of the consultation. We started on the 16th of January and we run to the 9th of April. And this slide highlights those areas we're looking at, and I'll explain in a bit more detail later why it's 2 phases. So the use of our hospital beds, so that's predominantly those on the John Radcliffe site and the Horton Hospital. Planned care, and when we say planned care, we're talking about things like outpatient appointments or diagnostic tests, and increasing that at the Horton. The delivery of stroke services for the whole of Oxfordshire, critical care services at the Horton, and the maternity services at the Horton. And as I say, we'll have a second phase of consultation later in the year. So why are we consulting? What are the things that are changing and making us need to consult? So the numbers of our population in Oxfordshire are increasing. The amount of healthcare we can give is increasing every year, and we're all living longer. And so there is more that we can do. So that leads us to growing demand. The funding that the NHS as a whole is not keeping pace with that demand. So if we carry on doing things in the same way, we won't have enough money. What we also want to focus on, the NHS is very good at focusing on spending its money on helping people when they're sick and treating them when they're sick, but we need to move to more to support prevention of ill health in our population. Even in a county with as good health and as affluent as Oxfordshire, we have some significant inequalities. And here in Oxford City, and Dr. Chapman will probably also talk about it, is there's an 8-year life expectancy difference between different parts of our population in the city. And that shouldn't be something that we continue to expect if there are things we can do about it. Again, there's always new guidance, new research that shows us how we can improve the quality and safety of the care that is given. The buildings and equipment we have across the whole of the county, across all of the different kinds of health services, so hospital services and our GP premises, are not all up to scratch, not the sort of premises that we want to be delivering care in, so we need to be able to invest in our buildings. And equally, our current workforce model can't meet demand, and that's for a variety of reasons. So one, because of the funding issues, but secondly, there aren't always enough trained staff in the country who can deliver some of those sorts of services, but also they won't always want to come to Oxfordshire because we're quite an expensive place to live. We've been asked in some of our previous meetings about why we're doing this in 2 parts. So there are a large number of services. The Clinical Commissioning Group spends over £800 million a year on a whole range of different services. And to get to the point of consulting, we need to have done a lot of work to look at what could the services look like, what are the options, and we're not ready on all of those areas. But there are some service areas, and these are particularly focused on where we need to change things to improve quality and safety, or where we've got temporary changes in place, and we think it's important that we reach a decision sooner rather than later about having the permanent solution. So for the proposed changes to our hospital beds, the Health Overview and Scrutiny Committee was very clear that we should be consulting sooner rather than later. Our maternity services at the Horton, again, we've had a temporary change in place since October, and we think for the residents of Oxfordshire, and particularly North Oxfordshire, and our staff, it is important that we reach our final decision on what's the best way to provide those services in the future. And critical care and stroke, as Dr. Chapman will talk about, are purely based on improving the outcomes for all of the patients in Oxfordshire and equity of access. And alongside this, we want to invest more in the Horton Hospital, so more people from the North Oxfordshire area can have their outpatient appointments and diagnostic tests at the Horton Hospital, and we believe that could save up to about 90,000 visits a year from the north of the county down to the Oxford hospitals. And then this is all in what are we looking for healthcare services in Oxfordshire to look like. We think it's important that residents of Oxfordshire can have local access to diagnostics and expert advice. So getting that as close to the centres of population as possible, spreading it around the county. Thinking about how do we prevent unnecessary admission to hospitals or going through the accident and emergency department. How can you have quick access, have your tests, have your care put in place, but be got back to your own home as we believe the best bed is your own bed when you no longer need hospital care. And at the bottom of this slide, you see what we think is a very telling fact, that 10 days in a hospital bed is equivalent to 10 years loss of muscle strength for the over 80s. So this isn't saying if you need to be in a hospital bed, that's where you should be admitted, but we want your treatment to be effective and efficient and support you to get home, and part of that is using technology. I think that's where. So I'll now hand to Dr. Chapman, who will introduce the different clinical areas.
Thanks, Catherine. First of all, it's wonderful to be in Rose Hill, which is one of the most deprived areas in Oxford City, in this building, which is a wonderful building, and the CCG that I work for part of the time is soon, I agree it's taken a bit of time, but we're soon going to be opening up part of the health area there to provide more services to people in Rose Hill, which will include things like ophthalmology, early pregnancy, and also extended primary care for people who find it very hard to get to other bits of primary care in the city. So very exciting to be here. About 6 weeks ago, I was in my surgery, and this a long-standing patient of mine, who's always quite difficult but used to come and see me, arrived, and he looked really unwell. And I thought, well, he very much looks as though he needs to go into hospital because I don't know what's wrong with you, and he looks that he needs some help. But he was absolutely adamant, I'm not going into hospital, doctor. I will not go into hospital. It's the last thing I ever want. So I had the advantage. I said, well, I have got a place in the hospital that I can send you to. You won't be admitted, but they'll look at you. They'll try and sort everything out as quickly as they can in that day, and then you can get home. And that's called the AAU, or the Ambulatory Assessment Unit, which is up at the JR here. And so I had a conversation with one of the consultants who works there at the JR, and we got my friend up there. He was dealt with, grudgingly at first from his point of view, but it's a very wonderful group of staff working there. They investigated him, got a scan, gave him some treatment, and enabled him to go home, where, over the course of the next weeks and few days, we were able to put in our wonderful district nurses who we have working with us, the Sobel house nurses, because it turned out that he had cancer. And after a few more visits to the AAU, it turned out that this was not going to be treatable, and that he was very clear that he wanted to die in his home. So, and that is indeed, he stayed at home. We were able to get the Sobel house nurses and the end-of-life matron and the district nurses and myself visiting very regularly, supporting him at home. And in fact, he died a week ago in his home, which is exactly what he wanted to do, with a great help from the AAU, which supported us to keep him exactly where he wanted to do. So I've been a doctor for 31 years now in the NHS, and it's a time, I suppose, of reflection that are we doing things right? Should we be changing things? Should we be listening to the things that patients want? And that is one of the things that's happened in Oxford and Oxfordshire, is the development of the AAU, this very high-powered unit which will support patients, investigate them, and get them home. And why do you want to get them home? Because largely that is where patients want to be. They want to be near their home. They don't want to stay in hospital. So we're listening now to what patients want. And most of the time, if they can get home, they would like to. But if they can't, then obviously it's appropriate for them to be there. So the changes that we're thinking about here is how do we look after patients to enable them to be in the right place for the shortest amount of time that they need so that they can end up somewhere better for them. And in the past, quite often, people would end up in hospital, but they didn't actually need any more medical treatment or support, but they weren't able to go home. So our whole focus has changed about this, and part of the changes with that is to try and make sure that people stay for the shortest possible time in hospital, and then they're supported to somewhere more appropriate, which may be directly to their home, or it may be to a better setting, which is not a medical hospital. It may be a community hospital, or it may be in a care home which is supporting them. And we have a system in Oxfordshire now, beginning, which is supporting people when they're out of the hospital to maintain them wherever they may be, if they're in a care home temporarily or if they're in their own home, until they're able to stabilise back to primary care, which is where I am. I'm a GP. And this is part of the process of what is happening across the whole beds. We're having to think, how do we use beds? And if we can get people home, and if we can close part of the number of beds in hospital so that we can build these special assessment centres, these AAUs, and have services out in the community which will support people, we feel that that is better for patients. And because we're now operating this, I think in general the feedback from most of the patients who've been through that system has been quite positive. So this is the sort of thing that is happening now, and we're intending to, if the consultation agrees with it, to embed in the whole of the system in Oxford. Are we going to just see a little? Okay. We're going to see a little film now to explain this.
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together, based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared-for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And they said, well, just thought it'd be good companionship for you, nice and be together. And I very much enjoyed it there, I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The Liaison Hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The Liaison Hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
So obviously that's a change in the way patients need to go into hospital. But of course, what we want to do is stop patients having to go into hospital in the first place. Now, in the 31 years that I've been a doctor, the pace of change in terms of technology has been phenomenal. When I first started, CT scanners were just experimental. Now we have CT scanners, MRI scanners, we have interventions, radiology, we have angiograms, we have point-of-care testing. That's testing, blood tests that you can test in primary care. I can measure how much oxygen you've got in your blood. So there's a huge change. So we have to think, how are we going to use that technology to help people stay at home? And part of the whole care that we're going to have changes, which will, if the consultation agrees with this, will be to move some of the things that we need closer to people's homes. So one of the things we're going to do at the Horton Hospital is to move diagnostics closer to people there. So more sophisticated diagnostics away from the JR over to the Horton. So 30,000 more diagnostics will be done in the Horton Hospital, which will allow the people from the north of the county to go to a more local place for investigations. On top of that, when we in primary care need to have a consultant input into that, there will be more outpatient appointments there. So there'll be 60,000 more outpatient appointments in the Horton Hospital. So it's not, this whole consultation is not about getting rid of the Horton at all. It's about how we develop the Horton in this day and age to meet the needs of our population. Of course, with technology and the changes that come on, we have to think, what is the best way of treating patients? And because we have very sophisticated interventions that we can provide to people now, it's much better for the sake of patient safety and quality that they have the right investigations and interventions in the right place. Some of these interventions are very, very take a lot of skill and technique. And the skill is developed, as you all know. It's a bit like if you play golf, you have to play it many times to get well. I mean, I've played it many times and I've never got well at it, but in theory, that's the way. It's very similar now with something. So stroke is an example of this, where now not only do you need sophisticated diagnostic machines to look at what the cause are, but you may be intervening and digging a clot out. Now, obviously, if you're very skilled at that, then you'd be very happy if somebody was dealing with you who has those skills. But you only get those skills if you have enough people who are seeing enough patients to do it. And that's why a lot of very specialist techniques are concentrated in areas, because you need to have these skills, build up the skills, see the flow through of patients for that. But stroke, of course, is not just digging out clots. It's how you do the intensive multidisciplinary assessment about how you're going to care for that patient. And that plan has been shown, the evidence is absolutely overwhelming, that those first 24, 48 hours assessment in an acute unit, which has a high throughput of patients, has much better outcomes than areas which doesn't. And that's called the hyperacute stroke unit. So because we have to concentrate those services, that can only be in one place, and we already have that unit in Oxford to get the throughput. So the changes will be, and in fact these are already happening. Anyone now who has a stroke that the ambulance men pick the patient up, it's clear it's a stroke, will be transported directly to the JR. So that already happens. They go in there, have an intensive treatment, and then a multidisciplinary team assessment to start the initial rehabilitation. Then, of course, some of the rehabilitation can then be taken to home, and we have a supported discharge service for that. Some will need more rehab. And then it would be logical, not that they stay far away from their home, but they go to somewhere closer to their home for the rest of the rehabilitation. So those are the plans that we think would be right on the evidence and the quality and safety for our patients to occur in Oxford, which is why we think that there should be one HASCU to get enough experience, hyperacute stroke unit. That will be in the JR. But then places like the Horton will be part of that rehabilitation if you cannot go home.
At present, we have an access of all patients to the John Radcliffe for immediate assessment driven by 4 hours from onset. With the transformations that have been undertaken in stroke care in the last 18 months or so, where mechanical thrombectomy, where we use devices to pull out clots rather than just using drugs, we need to get patients to the John Radcliffe to enable equitable access from the whole county to this life-changing treatment. This is a very intensive, highly specialised intervention that very few centres in the whole of the UK can provide. And we're very fortunate that we have one of those centres here in Oxford. We also need to provide equitable access to the rehabilitation that enables the best recovery for patients. Through the early supported discharge service, which we hope to expand from the 6 postcodes it currently covers to the whole county, we hope that we will enable patients to have therapy in the comfort of their own home, enabling them to have therapy targeted and ensuring that they maximise their chances of returning to functional independence in the environment where they're going to spend the rest of their lives. And that's the whole purpose of the ESD being incorporated, early supported discharge, incorporated into this consultation. When it comes to immediate access to a hyperacute stroke unit, the major benefit to patients is the immediate assessment with specialist imaging and access to immediate specialist assessment by consultant staff, both physicians, such as myself and my radiology colleagues, where we can make the immediate decision whether mechanical thrombectomy is potentially helpful to patients. This is a decision where an immediate assessment and immediate decision really do enhance the chances of patients returning back to how they were prior to their stroke.
So in the late 1980s, when I was a registrar here at the John Radcliffe Hospital, I worked on the renal unit as the renal unit registrar. And some of you might remember Des Oliver, who was the consultant there, who was one of the first people in the country and in the world to use dialysis. And it started off in a sort of Nissen hut on the Churchill site and developed from there. We never went on to ITU to give dialysis because it wasn't thought it would do any good, because people would die, unfortunately. And in fact, ITU, the intensive care unit there, was not that sophisticated, but tried its best. But over the years, as has happened with technology, the whole perspective around intensive care has changed. Technology has changed. There used to be an age limit. You wouldn't dialyse anyone over the age of 65. Now, there is no boundary at all about when you do it. And ITU is a very, very sophisticated place there. The critical care is very sophisticated. So, again, you need expertise. If you were critically unwell and you needed support, I suspect most of us would want to go to the best place. And as with all these things which involves technology, it needs a team which is very familiar with how to do things in complex situations. Unfortunately, at the most complex level that goes to the Horton at the moment, if they had the top tier of complexity, they'd have about 1 per week going through the Horton Hospital. And that is not enough to maintain those skills. So, in fact, now what happens is that patients who are what they call Tier 3 get transferred to the JR, where you have very skilled teams that are there 24 hours a day with dealing with multiple organ failure. And I suspect that's the sort of care that people would like. Of course, once you have recovered, if you do recover from that, then it makes sense that you could then step down to somewhere where you didn't need that sort of intensity. But that sort of change in the way that we do things is advanced because of the technology that we had, but also because patients demand the best that they can get. And that's not unreasonable at all. So the changes that we would propose at the Horton would be that they don't take the sickest of patients, although they'll have the ability to stabilise those patients who will be then transferred to the JR. Maternity, I was very lucky because I worked for about 18 years as a GP in Oxford City, but I also used to work in the obstetric medicine unit at the John Radcliffe Hospital, which some of you will know is run by Professor Redmond, who's a sort of world-renowned figure here. So we've always been used to dealing with very complicated pregnancies. And we have always sorted pregnancies out into different levels of risk. So high-risk pregnancies, when you've had the ability to sort them out, have always come to the John Radcliffe Hospital and been looked after there. Now, of course, what happens when you haven't, you don't know what the risk is? And then, of course, you have to deal with that as it happens, because these things do happen. Pregnancy can be very safe, but it can also be a dangerous business for some patients. So my wife, as it turned out to have high-risk pregnancies, 3 high-risk pregnancies. That wasn't what we were expecting. We were expecting a birth pool in our front room, but unfortunately it didn't happen that way. And in the end, we were very happy that we were looked after at the John Radcliffe Hospital. If you're low risk for your pregnancy, so we think it's actually safer and better to be in a midwife-led unit. And the evidence for that is very clear. There are less interventions, there are less instrumental interventions, and low risk of caesarean section. So a midwife-led unit, rather than being second best, is actually number 1 if you're a low-risk pregnancy. So throughout everywhere else in Oxford, we have maternity-led units. In the Horton, they did have an obstetric unit there, and at the moment we've had to close that. That's partly because it's been very hard to keep it running in terms of getting obstetricians. So what's operating there now is a midwife-led unit. So if you're a low-risk pregnancy, that's absolutely the best place for you to be. If you're a high-risk pregnancy, the JR or other hospitals around may be the place, obstetric units may be the best place for you to go. And as I said, that sort of sorting out of risk always used to happen in maternity. So in many cases, this is not a new process at all.
We want to provide a high-quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of 2 groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. There's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, the pregnancies are more complex. And actually, as the health service developed, We now find that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
So we're coming to the end of the presentation, and this just tells you how else. So the meetings are only one way you can get involved. All of our documentation is available on the website, and that web address is also on page 42 of the consultation documents that are on your tables. You can write to us as a free post address. There's a questionnaire online. There are hard copies of the questionnaires here. And there's be more opportunity in the rest of this meeting to have your say. And then the final slide has the dates. We are holding these meetings at different times in different venues all across the county, all running to a very similar format, but anybody is welcome to attend any meeting. Thank you very much.
Okay, we'll start with the questions. Would anyone like to kick off with a question? Lady at the front with the purple scarf. Just bear with us, we'll get a microphone to you. The microphones are important, not just because we can hear you, but because the audio is being recorded as well.
Okay, it's simply a clarification. This AAU, this ambulatory assessment unit, is that for older people or whole age range?
It would work for any age range, but it certainly works for older people as well.
Just a clarification.
Okay, thank you. The lady with the beige cardigan on just behind you. There you go.
Why is it good to move diagnostics closer to people in Banbury, but 2/3 of the maternity cases further away? The figures here say there were 1,466 births approximately, and it also says only 200 to 500 of those, which is less than a third, would choose a maternity-led unit.
Okay, thank you. Who would like to answer that?
Yeah, so why don't I answer that? I think the important thing is that these are two different issues, so it's good to have anything you can have near a home if you can have it. And so the diagnostics are interventions, procedures, investigations that are done on people, generally speaking, who are relatively well, who are able to get about. And so, in a sense, they're by definition low-risk procedures. Clearly, by making this change, we're talking about 30,000 visits to Oxford that can be avoided, which is great for the people of Banbury. It's also great for those of us in Oxford using the hospital and worried about parking and those sorts of things. But where we get to the maternity services, there we're talking about women needing to deliver their babies. And so all of that discussion we've just had about risk stratification is immensely important. And it isn't fantastic to have to go and deliver in Oxford if you live in Banbury, but if you cannot have a safe obstetric service in Banbury, you have to go somewhere where there is a safe obstetric service. On the other hand, if you don't need an obstetric service because you're low risk, then you can deliver in a midwifery-led unit in Banbury, or you can choose to come to the alongside midwifery-led unit in Oxford, or you can choose to book into other services elsewhere, South Warwickshire, Northamptonshire, and so on. So I think to be honest, it's about a matter of necessity that because we're not able to offer a safe obstetric service, those women who are higher risk and need that for their delivery have to come to Oxford or to another unit that can offer that.
Okay, thank you. The lady there with her hand up with the purple scarf. Would you be kind enough, I didn't ask the other ladies, would you be kind enough to give us your name because of the audio being recorded? Thank you.
Yes, I'm Sarah Lazenby and I live in Oxford. I'm going to ask one or two short questions and then the punchy one. One is, could you tell me if you've done a risk analysis of travelling for over an hour in a complex obstetric case? What does it do to your statistics? Two is...
Can we take one question at a time? So the first one is...
The level of risk of travelling over an hour. And you may be longer because your ambulance may be in a list,
sure,
in a queue
course.
And so on.
Yeah. Okay, let's get it on.
Has anybody done that risk assessment?
Okay, let's ask that question.
So the answer is yes, the risk assessments have been done around that. We've obviously made reference to the published information and the data that we can get from ambulance services around travel times, and we are content that the overwhelming majority of transfers are made comfortably within an hour, as you put it.
Okay, your second question.
I don't think that's what I asked.
Okay.
I was asking not how long does it take, because it will take different times in the middle of the night or in the rush hour, quite significantly different. That's why I said generally over an hour. What I asked was, how does travelling for that length of time raise the risk to the mother and the fetus because they're doing that journey? They may have to do it for even further away in the very north of the county, which is, I don't know how much longer, but it might be even 20 minutes, half an hour. Have you done that assessment? Not the assessment of the length of time, the assessment of the risk involved.
Okay, let's get an answer to that.
So again, yes, we have done assessments of risk in relation to travel time. I think it's important to understand that we're offsetting the risk of travel against the risk of coming to a unit where there are no doctors able to look after those women at all. That has a huge impact on the risk. It's also important to understand that the majority of labours that we're talking about that would be happening in midwifery-led unit are run according to very strict protocols, and there are transfer protocols that operate so that as soon as there is evidence of failure of the labour to progress, that transfer can be expedited. And I think the evidence around that is that those transfers, generally speaking, happen in the early stages of labour, so there is plenty of time for that transfer to happen and for delivery to take place. You know, of course, no one is in a position to promise that there will never arise a situation where a woman is transferred while she is labouring and delivers in the ambulance. But the reality is we already have women who deliver on the roadside in Oxfordshire, whether it's in North Oxfordshire or South Oxfordshire. I'm afraid that pregnancy and labour is like that. And so, what we are saying is what is the best possible arrangement for the whole population, low risk, high risk, and what are the best arrangements we can put in place to provide the best outcomes for everyone.
Okay. Before you come on to your second question, is there anybody else here who has a question relating to the lady's question here? The gentleman at the back, the microphone's just behind you. And again, please give us your name. Thank you.
Press anything?
Yes, no, it's fine. It's on.
Yes, the last time that the maternity unit at the Horton was closed temporarily, was in 2008, I think. And at that time, that was referred to the Secretary of State, who passed it on to something called the Independent Review Panel. And the Independent Review Panel thought that the distance on a poor road between Banbury and Oxford was inadequate to allow safety. We're now in a situation where history is repeating itself. The Health Overview and Scrutiny Committee on February the 2nd, I think it was, decided that they should refer the temporary closure, which has been going on and on and on and might become permanent, clearly, of the obstetric unit at Banbury should be referred to the Secretary of State, and they are in the process of doing that. It seems to me that the Secretary of State or the independent review body may very well say that there should be obstetric cover at Banbury, in which case everything predicated on closing it and downgrading the hospital in Banbury from a general hospital, a kind of small district general hospital, might have to be rethought. And consequently, this consultation, which is mainly, as far as I can see, about Banbury, and the issues that are raised by shutting it down to, I'm very pleased to hear about the investigative potential that there is going to be there, but it is nevertheless not going to be, because of the beds that are being closed down, it is not going to be anything like a general hospital.
So the question you want to put to the panel, I'm just conscious of the time, forgive me.
Right.
What question would you like to ask the panel?
As far as the essence of my question is, because it's been referred to the Secretary of State, what is the CCG and what is the OHT going to do about it?
Okay, thank you. Andrew, please.
So I think I'd start off by saying I think we all think the Horton has got a really positive and vibrant future. Things can't change. You've heard from Dr. Chapman how medicine has changed, how needs have changed over the last couple of decades. And so it's absolutely important, if we're going to continue to provide modern, safe healthcare, that those services change as well. To respond to your specifics, in 2008, obstetric services weren't curtailed at the Horton Hospital. We were facing staffing difficulties at the Horton, and for those reasons, we put forward proposals similar to those now. In terms of what has changed, there have been a number of changes. So the first is that the Horton no longer has training recognition for junior doctors. So that means that we can't now have doctors in training working at the Horton Hospital. The local deanery who decides on those training matters decided that for doctors to be adequately trained so that when they go out and practice independently, that they are safe in obstetrics, that when they are adequately trained and safe to operate, that they need to see a certain number of patients, as you heard Veronica Miller, one of our leading obstetricians, say. So that's number one, we can no longer put doctors in training at the Horton. Secondly, there's been, as you've heard, research that has shown that for low-risk pregnancies, actually women being delivered at a midwifery-led unit have better outcomes than they do if they go to an obstetric unit. So that research is new. I think the third element is not only have we lost training recognition, but nationally the position of the number of obstetricians available to fill those posts has gone down nationally. This isn't an Oxford issue, this is a national issue. When you combine that with the fact that we can't put training doctors at the Horton, we simply, as Dr. Berendt has said, can't run a safe service. And so it is for those reasons that, and for those changed circumstances that we have again had to return to the proposals that we are putting forward. On your specific question about the position in terms of HOSC themselves were keen that we as a health system went out as early as possible to public consultation on the issues because we had already had to take temporary emergency measures. In terms of what we as a system can do now, I'd just remind people that the decision was taken, as has been said, for patient safety reasons because we could not find the doctors to safely staff the unit. Nothing in those circumstances has changed since that temporary arrangement was put in place. We have continued to try to recruit, but as yet we have not got sufficient doctors to open up the service safely. So that remains the position.
Can I just come in on the back of that, since one of my roles is what's called the responsible officer, which means I am required to be the single person accountable for the quality and abilities of the doctors that we recruit. I've personally reviewed all of the applications that we had for the multiple cycles of attempted recruitment to that unit, and I'm absolutely satisfied that we've done the very best we can to recruit people of an appropriate standard, which for that unit would mean people capable of carrying out a caesarean section independently in the middle of the night. So these are not people with minimal training. And the reality is, the sad reality, but perhaps the rather obvious one, is there are not large numbers of well-trained, experienced obstetricians sitting about waiting to take a job in a unit that delivers 4 babies a day, not all of which need the services of an obstetrician. So there is an element, I think, of pragmatism here, where we have to understand that the times have changed in relation to what it's acceptable to have by way of medical staffing and what it's possible for us to sustain.
Okay, lovely. The lady who has the microphone over there. Thank you.
Thank you. 2 new issues I'd like to discuss. One is the issue of inequalities. And it's good to see that the issue has been acknowledged.
Would you just put the microphone closer to your mouth? Thank you.
But I was wondering if you could explain how these changes will narrow the inequalities gap. And my second question is around social care and how you see social care working with your proposed changes. Thank you.
Okay, so your first question was about inequalities. Yeah.
So thank you for those questions, Glynis. So the work has started on the integrated impact assessment, but that's ongoing work. And as we do more detail, all of that will be published, and we will be looking specifically about the impact on different groups of the population and how that's affected. And if it is potentially, but we don't know, going to increase inequalities or make them worse, how would we mitigate that? In terms of social care, the County Council as a whole, so Public Health, and I'm very pleased that our Director of Public Health, who's also a member of our board, is with us tonight. The County Council, Social Care, Public Health officers and councillors are with us on our Transformation Board when we're having the discussions about proposed changes. But the issues we are talking about in this Phase 1 consultation are specifically issues about health, the safety and quality of very specific health services. So we agreed that we were, as a health system, running this consultation, but we continue to work very closely with our County Council colleagues and work with social care and think about our integrated community teams who support patients who are discharged from hospital and need that support.
Andrew, you want to come in?
I suppose just to build on what Catherine has said, these changes are very important, but they're not the only changes going on within the local health and social care service. The CCG has recently set up a Health Inequalities Commission that has published its report, that has come up with a series of recommendations for all health bodies and social care and indeed voluntary sectors and a range of other bodies about action that we can take to try and address those health inequalities across the county. And for our board, for example, we have looked at that report. We took a report to our trust board, public trust board in January that identified which of those measures are important for us as an organisation to take to help us address those inequalities. And we're in the process now of turning that into an action plan. So there's a great deal of work going on across the health and social care sectors to look at what we can do around health inequalities, not just the changes you're seeing tonight.
Okay, thank you. The lady in blue.
I very much welcome the idea of midwifery-led units for that, but I must say that if the system you're proposing were in place when I was having my first baby, and we're thinking of living in Adbury, I wouldn't be here now, nor would be my baby, because it was late in the pregnancy that they realised there was a crisis. And it was so critical, the emergency, that I think I did probably have some brain loss, because it was quick and I did lose oxygen to my brain for a time. So that's one of the things that worries me. This is the sort of thing difficult to predict and care for. That's the comment I wanted to make. The question I wanted to make is, it seems the wrong time to be doing this. Also, I'm afraid that dreadful word Brexit comes into it. I know already that you haven't got enough accommodation for the people in your hospitals. If the people who are willing to sort of live all together in certain houses, leave our health system, we're going to be in a difficult situation. In that sort of situation, as you said, Oxford is a very expensive place to live. Banbury, I'm sure, is less expensive. It seems a shame to put all your eggs in the basket of Oxford and not use Banbury to a further extent. The last thing I wanted to say is, am I right in thinking now, in these proposals, you are adding a swathe of Buckinghamshire and Berkshire to people who are going to be using the JR? And it's already at stretching point. I'm concerned about that.
Okay, so you're worried about having enough staff, and you're also worried about the JR being overloaded from surrounding counties?
Yes, okay. And the fact that somebody in a serious, sudden change in their pregnancy will not get to the hospital in time, and it will mean people dying.
So obviously I'm sorry to hear you had a difficult experience when you were in this position some time ago. I think what we'd have to say is that we have to design services based around what we think provides the maximum benefit and the best outcomes to the largest number of people. And that is what we're doing in relation to these proposals. I think it's also important to understand that the current situation, as I've tried to explain, is a situation that we did not invent. We have responded on grounds of safety to a position that has been evolving over several years, as Andrew's already mentioned, ever since the loss of training recognition. It's important to understand that we're not unique in this. Oxfordshire is by no means the only place where there are similar issues of different hospitals at different distances from each other, and decisions have to be made about how to come up with services that are in the long term sustainable. And I think, as I've tried to explain, there is a great difficulty in recruiting obstetricians into the unit in Banbury at the moment. Options to seek to have permanent consultant presence in Banbury would require a very large number of obstetricians to be based there, as well as the numbers in Oxford. And that is, I think, something that, again, is difficult to contemplate being possible to sustain. I think in terms of the issues around Brexit, we all share that anxiety that there may be major impacts going forward on the workforce in hospital and elsewhere. I'm not sure that strengthens the argument to split the workforce up between sites, but I'd like to assure you that we have not been working up proposals to close the Horton Hospital. I think there seems to be a view out there that we're intent on downgrading, as people put it, everything there. That's not the case. We're intent on running safe and effective services for the largest possible number of people. Hence the intention to focus on reducing the numbers of Banbury and environs residents who have to come to Oxford for routine outpatients and investigations. We also have plans to increase the amount of day surgery that's there, and I would remind anybody with an interest in the Horton and Banbury that we've put substantial investment into that site: new endoscopy suite, new radiology department, new areas around paediatric outpatients. There's been significant investment over years there. We are very committed to that site.
Okay, thank you.
So shall I just pick up the question about populations of any county area will tend to use the closest hospital for some of the straightforward services. So for some of our Berkshire residents, that would be Reading Hospital, and in Buckinghamshire Hospital there are specialised services that the John Radcliffe provides for wider counties and has done for a long time. But equally, some of the residents of Oxfordshire, so some of our residents who live down in Henley and the south east, would go to Reading for hospital services. Some of our residents in the southwest of Oxfordshire go to Swindon. So where services are available at more than one hospital, patients get to choose which is most convenient for them in terms of access. And that will continue under these proposals as well.
Okay, thank you. You had a second question, didn't you?
Yes. The other question is, I don't think we're considering mental health today, are we? Is that right?
Let me ask the panel. Mental health.
But even if we're not considering mental health as such, you're going to reduce the number of beds in the JR when there are far too few beds in the mental health provision. And it's grim. My neighbour's mother was as mad as a coot, and it had to wait from Sunday to Tuesday to be sent to Windsor to find a bed. I mean, she was brought back quite quickly. But anyhow, that's, I think, probably quite typical. So if you are going to close 24 beds in the JR, could you consider, and I don't want an answer to this, could you consider that they might be usable by certain people who need a mental health bed? What I wanted to ask you was, if you had a diminishing population, we have an increasing population, if you had a diminishing population, what would you or would you not do? Would you, if it was a diminishing one, so you had plenty of money to do what you want to do. Obviously, if you have an increasing population, the money doesn't stretch as far.
I think the panel would wish that they had plenty of money to do more. Let's ask them that question, though. It's hypothetical.
So if we had a diminishing population, the clinical commissioning group would get less money, because the money we get is dependent on the population that we have. But actually, with these proposals, they're not about the money. They're, as Tony and David have said, these are about getting the best outcomes and the best quality services we can for the population of Oxfordshire in these particular areas.
Okay, thank you. The gentleman there with his hand up, if that's all right. I'm sure he won't mind sharing. There you go. All right. You can go first, please. Thank you.
My name is Mark Ladbroke, and I worked for many years in the NHS. I'd like to ask two questions, one of them about process and the other one about workforce. And if I can ask the one about process first. There's been really very considerable concern expressed about the STPs across the country and locally. And people are really concerned about the impact on services. So our MPs have expressed concerns about it. Our County Council passed a resolution backed by every single councillor in every different political party about it. Our City Council expressed concerns about it. As people have said, the HOSC, that is the Health Overview and Scrutiny Committee, which is part of local democracy, have done the maximum thing they're allowed to do, which is to refer elements of this to the Secretary of State. There is a huge level of concern about the SDP, nationally and locally, because, as you know, has been quite properly pointed out at the beginning of this, we have growing population, an ageing population, and actually we have inadequate funding to carry on levels of treatment that exist at the moment. So, because these elements have been, there's such concern about it, because they've been referred to the Secretary of State, don't the panel think that really it is responsible to stop the consultation and actually say, let's see what the Secretary of State has to say before we push ahead with this, so that we actually know what we're consulting on, rather than having serious elements of this out. You know, how can we consult on the elements that are out being dealt with by the Secretary of State at the moment?
Okay, so the question is, should they stop the consultation
yes.
while the Secretary of State is looking at considering it? Let's ask that first of all.
Thank you, Mark, for the question. So, just so that we're clear, the Health Overview and Scrutiny Committee last week talked about referring two different items to the Secretary of State. One was about primary care services in Witney, which is not part of this consultation. The second was, our understanding is about the temporary closure of the obstetric services at the Horton Hospital, and that the referral has not yet gone. We checked today. They expect to be sending the letter tomorrow, so it is not yet clear exactly what basis they're making that on. If they make that referral, they are referring the decision of the Oxford University Hospitals Trust Board on that. Until we are clear about what's being referred and why, and this is about what we think should be the permanent solution for these services to ensure they are safe, sustainable, and we can staff them, we believe we should be continuing with the consultation. If it is clear that there are things we need to consider, we will do that when we see the letter from the Health Overview and Scrutiny Committee.
Okay, thank you. And the second question?
Okay, thank you. And could we have that letter published, please, so that people are aware of it?
The audio in here is being recorded anyway,
right, okay,
so it will be on their website.
Okay, thanks.
So it will be a matter of record.
Okay. And the second question is about staffing. And when you go now into our local hospitals, you see a United Nations of staff there, as people have mentioned. You see Spanish nurses, Italian nurses, and it's such a pleasure to work with people from around the world and to be cared for by people around the world. It's very, very positive. But there clearly is a big staffing issue in the local health service. And it was very worrying to see this report talking about staffing and that you plan to save £34 million on workforce costs. So, if we're struggling with staffing at the moment, what will the situation be like now if we take 34 million out of the staffing budget? This really is extreme. I appreciate the difficulties the panel have with inadequate funding, but this is very, very alarming. And this is part of the reason that so many people are concerned about the situation.
Okay, let's see if we can get an answer to that.
So, Mark, I think you're quoting from the overall sustainability and transformation plan funding, not the specific consultation and document we're talking about today. Is that correct? It's the Bob, yeah. So the overall Buckinghamshire, Oxfordshire, Berkshire West Sustainability and Transformation Plan is an overarching plan. The Oxfordshire element of it is predominantly the Oxfordshire Transformation Programme, part of which we're talking about today. And the way some of those figures have to be calculated, and maybe Gareth will help me out in a minute, is it is about thinking about what might we have to spend in the future if we carry on doing things in the same way that we're doing them, and we won't have that money. So I think it's again about being clear. The NHS is getting slightly more money each year. We're not having a cut in our budget, but we're not getting enough more money to carry on doing things the way that we do. So we will still have the same amount of money, if not slightly more, to be spending on our workforce. I think what we're trying to say is that workforce might need to be different, need to be working in different places in different ways.
Okay. Can we look at the specifics of that when we do the round table? I'm quite keen so that you can all get to the round table, if that's all right. There was a lady there, first of all, and then I'll come to the gentleman there who very kindly passed his microphone on. Fire away, please.
Okay. Joan Stewart. I think we need to be clear why we're all here. And it's about cuts. It's about chronic underfunding of the NHS. It's about chronic underfunding of social care and public health. And I would be delighted if a third of what's presented in here actually came about because it was considered clinically possible and clinically beneficial to patients. But what I suspect, and I haven't heard much to counter it, is that these plans are to do with cost cutting.
What question would you like to ask the panel
question
about
that I want to put is that much of this is predicated on expensive hospital beds, that you have already closed beds and you're due to close more. And the assumption is that the community and the rest of us as carers are going to pick this up. So where is the evidence? Monitor, part of NHS improvement now, and the Nuffield Trust, hardly lefty organisations, have said that there aren't cost savings to come from moving care from hospital beds into the community. And I have looked in the documents to see where the evidence is. And you talk a lot about public safety. And I wonder where's the evidence that community-based schemes are, one, safely absorbing the extra demand created by the closure of these beds across the trust, 146, I think, and rising, and two, delivering the savings, in other words, the cuts, that the STP was designed to make.
Okay, so the question is, where's the evidence?
I'm happy to start with consideration of the hospital-related matter. So the first thing to be clear about is this is not the STP that we're talking about. This is the Oxfordshire Transformation Programme. They're different things. No, they are. They're different things. Well, okay, they are different things. So the second thing to say is that there are certain things that I'd hope we can agree on. I'd hope we can agree that 40 patients requiring level 3 intensive care at the Horton would be much better served being in a unit that looks after hundreds of level 3 patients than in a unit that looks after 40. That's one of the elements of the consultation. I hope we'd all agree that that is a sensible thing to do and provides equity of access for those 40 people to the highest quality, most experienced intensivists available to them. I hope we'd agree that providing equitable access for 100 patients a year from North Oxfordshire to our hyperacute stroke unit is better than sending them to Banbury. I hope we'd agree on that. That's in the consultation. No, it is part of your question, because what you're saying is that it's all based on cuts. And it's not. It's based on quality. It's based on providing quality of care for those patients. And I think that we've already tried to convince you, and we have very clear experience of this now, that by moving patients faster out of hospital and placing them either back into their own homes through our supported schemes or into intermediate care beds in nursing homes, those patients experience better outcomes than they would when they were stuck in hospital. And that's been very clear to us. We've moved over 500 patients through that process. The experience has been excellent. The responses from the patient experience surveys have been overwhelmingly positive. The readmission rates have been less than we expected. Many of those patients have successfully gone through to home. Obviously, some of them have remained in the nursing home sector, as they might have done had they been stuck in hospital. What we're talking about here partly is having to rework our idea that the best thing for a person is always to be put in a hospital bed, and that if they can't be in a hospital bed, it must be bad. And that is simply not true. And it is not true that health economies that are able to contain their costs provide bad outcomes. There's lots of international evidence on that. If we look at places like Jönköping County in Sweden, we know that highly integrated health and social care systems can produce excellent outcomes for very good value for the taxpayer. So I completely reject the notion that this is about cuts. This is about us trying to get these services into the right kind of shape for the future. And yes, there may well be elements of the total transformation programme that do ask the public to look more at how do we do more self-care, how do we do more care for each other. That is a possibility that we all have to face, I think, as we continue to increase our health demands, and as, let's face it, the economy shows no signs of suddenly producing lots of extra money for us. So I think we are all, certainly at my end of things, we feel absolutely obliged to be good stewards of public resource and try to get the best possible health outcomes for what we've got.
Andrew, would you like to come in?
Just to add what Tony has said, the money that has been saved on the acute beds has been ploughed back into community health services. It's been ploughed back into buying more care home beds so that patients who don't need to be in a busy, inappropriate acute hospital can be in a more homely setting. It's been used to expand the home care service that we as a trust provide. So we've greatly expanded the number of staff that we have got who provide home care to care for those patients. It's been put into extra therapy staff, extra community nursing staff, and extra medical staff to provide the medical support that those patients out in the community need. So that money has been reinvested into providing the better clinical outcomes that Tony's just described.
Okay, thank you. We're going to take two more questions and then move to the round table. So with questions like you've just asked, you might have the chance to ask in more detail, face-to-face, with people at the round table. Is that all right? Okay, gentlemen over there, and then we'll come to the lady, then we'll move to the round tables.
To follow up various comments and questions, a year ago I looked at the spending review produced by George Osborne, who fortunately has left us. My conclusion was that the numbers simply didn't add up, that there weren't the resources within the NHS sector to provide adequately for social care, and that in any case was only going to start making a difference in 2020. I may have read it all wrongly, but I suspect not. The assumption seems to be that by reducing the number of hospital beds, people will be able to be transferred to care at home, care homes, nursing homes, in which case one may well ask the question, but why hasn't that happened already? If that does take place, we need to look at, to be blunt, the quality of care which is available, particularly in care homes, from which there are a number of very, very negative reports throughout the country. This is only likely to be worse because the problem isn't money so much as bodies. You've got to actually find people to do the work and to get paid the salaries. This is nurses, These are people working on the care sector. These are people who are to be excluded from Britain under Brexit. These are people whose coming to Britain is undesirable, whether they're from Zimbabwe, Ghana, Spain, or elsewhere. So my question is not where does the money come from, but where do the people come from on whom the money could otherwise be spent? Thank you.
Okay, thank you. We've touched a little bit on that before, but let's just go back to Catherine. Tony, you were talking about the people coming here.
So I think your questions are really important and a good one. But the question is the same, whatever we do with the configuration of services. It makes no difference whether we're asking that question in the current configuration or in the new one that we propose. The difference is the new one that we propose, we believe, has a better chance of integrating ultimately with other elements of change to deliver better outcomes overall. So let's try and work this one through. If we have a lot of older people who are stuck in hospital for weeks on end, unable to get the right inputs, psychologically demotivated and dispirited in an acute environment, exposed to risks in that unfamiliar environment of becoming incontinent, confused, falling and injuring themselves, picking up some kind of an infection. And, I don't like to say those things happen because it's my hospital, but of course, from time to time they do. All of those things are harms that those patients have received by being stuck in hospital. It costs us a great deal of money to be able to look after people in a hospital. If we can't recruit enough staff, we have to spend even more money on agency staff to keep them there. If, on the other hand, we can close those beds and invest that in resource instead in intermediate care in nursing homes that gets people into a situation from which they can rehabilitate faster, which we have been doing, and that allows us to support people in their own homes better, which we have been doing, then it seems to me we're onto a winner. It does not solve the long-term problem that we may still have issues about the totality of social care provision that's available. So I agree, there's stuff that we as a society will have to look at. But I'm simply trying to work out, from the hospital point of view, what looks like being the best way to get the largest number of better outcomes for the largest possible number of patients. And I think it's with this reconfiguration, not with carrying on keeping 150 people stuck in hospital because we've used up the resource to keep them there instead of providing the resource to get them home.
Okay, thank you. We'll go to the lady here and then we'll move on to the roundtables.
Hi, Sarah Wilde, St Clement's practice. And I don't really know all that much about what you're talking about. To me, it just seems like you're playing poker dice, and if the dice happens to come up in the colours you want, well, that's pretty good. But I don't think that's the way to handle people, especially as you say, your main statement here is that we want to bring more care closer to home in Oxfordshire. Well, that's a laugh. I mean, the social care budget doesn't cater for people who want to get out of these beds. A friend of mine was in an emergency bed for 3 months because there was no social care available to her. And then when she did get it, what happened? The Quality Care Commission closed them down because they were such a rubbish organisation. They had terrible staff. So I don't think you can go ahead and just say, well, we're going to do this with this tiny little section of our care needs, and we're going to ignore the social care, we're going to ignore a whole range of other issues, because actually that's not our remit. Mental health, what happens in Witney, that's not our remit. We're just going to deal with this.
So your concern is social care and what happens to people if they're not in the hospital beds. Andrew.
So I suppose just to repeat what I said earlier, because I think it's an absolutely important point, and it's one that we're trying to address. So in the scheme that you've heard described here, you saw the video of the hub, there is additional money going into social care that money is coming from us being able to free up the money associated with having patients in our beds who no longer need to be there. So we are employing social care workers to go into those people's homes to provide that extra support that they need. So we recognise everything you say, and that's why we're trying to promote the approach that we are putting forward to you tonight. As Tony says, we are providing better outcomes by moving money out of the hospital for those patients who don't need to be there and investing that money in providing more social care. That's exactly what... None of the patients we are talking about are sleeping rough. We have followed them all up. We can provide you with the survey that we took of those patients that provided overwhelming endorsement that they thought that the care that they were getting was better under the proposals that we've done, because their relatives, their loved ones, and the patients themselves were saying we didn't need to be in an acute hospital. We could go into a nursing home, we could go into our own home where we're able to recover better, where we're able to resume our normal daily living much better than being stuck in a hospital, which was inappropriate for us. Okay. We can provide you with that. There's a report that we had to provide for the Health Overview and Scrutiny Committee that we will make sure is available on the consultation website that provides the evidence for that.
Can I just say,
yes.
We've heard a couple of assertions from the floor that nursing homes are terrible places, and that's how I thought also before we started this programme. But we've been and visited these care homes, we've worked with them very closely, and frankly, I've been extremely surprised by how positive the patients have been about it and the staff, and you've seen a little bit of it in the video, but maybe not as much as would have been possible, how positive those experiences have been, how many very motivated, decent, compassionate people there are working in care homes who are very keen to develop new skills and who are actually intent on providing really positive environments for those patients. And of course, the ones that are closed down by the CQC make the news. Of course they do. But the rest of it may be entirely different. That's not, I think, being reported. And our experience has not been that these are bad places for patients to be.
Okay, let's move to the round table now. You can go into more detail and face-to-face with the panel here. Ali Green will just explain how it's going to work.
Okay, thank you very much. Clearly, there's more questions and more comments in the room than we've got time to allow for now. What we wanted to do was to make sure that everyone in the room has a chance to share their views on this consultation. And just be aware, the presentation we've had has really tried to explain the areas where we are out for formal consultation. Every table in the room has got members of staff and members of the boards from the Clinical Commissioning Group and the Hospital Trust. So you are joined with people who know a bit about what it is that we're talking about. And we're here to listen today. We've got 3 key questions we're asking of you, and your table hosts and scribes will help you work through those. We've probably got about 15-20 minutes, and then we'll convene back again. So thank you.
Hello, hi. Just to let you know, we've probably got about another 5 minutes before we have to close. If somebody from each table can summarise the main points at the end, that would be great. So probably about another 5 minutes, and then we'll call it to a close. Thank you.
Right, okay, there we go. Sorry.
Okay. All right, ladies and gentlemen, we are going to have to close now. Could I please ask somebody from each table to give one, we've only got time for one main point from your summary, please. If we start, should we start with the table here? Are you not ready? Yep, okay. Just one main point. Hold on for 1 second. Let's just hold on for 1 second so we can hear the gentleman speak. So one main point.
Can I choose one first?
Of course you can.
Lack of community care. Lack of care.
Okay. The concern that was raised on our table was around the quality of community care and whether this new system would be able to provide adequate resources and outcomes for patients. Does that sum up what we were talking about? Good.
I can see the table in the middle is nodding as well. Is yours a similar point about care?
Well, actually, the summary sentence would probably be, yes, we've made the case for ambulatory care and indeed stroke, but there are concerns indeed about community care, and felt there wasn't enough basically presentation of the downsides of the options presented. And also, there wasn't enough about health inequalities.
Okay, thank you. We'll just move over here.
So continuing on the community theme, the big message was transfer to community settings is window dressing unless sufficient funding is available.
Okay, we'll move over to this table here. There you go.
So I think it was very similar to the point that's just been raised. It's about the need to be clear on the investment and the value we're getting out of closing beds and into community services.
Thank you. And the table here, what's the main point you'd like to make?
So a similar issue around need to get more of the resource away from hospital care into prevention, into primary care, and particularly an issue about health and social care really need to work much better together.
Thank you. We'll move to the table in the middle. Who would like to make a point there?
Thank you. So one of our challenges, we did have a big discussion about finances. However, we also had a focus on the problem with perception of the public and how we get messages about how healthcare is changing clearly out into our communities.
Thank you. Who would like to summarise over here?
I'd like really to ask the board to comment on something that we were discussing, and that is this sort of the nature of the process that we've all been going through, and how strongly people feel, and sometimes very distressed, about the changes that have been what we think, what we believe and know to have been foisted upon us. Given that we appear to be at the end stage of an implementation. And I want to draw everybody's attention to something that was said, or at least written in the Health Service Journal today, that Simon Stevens said this morning, who's the Chief Executive of NHS England, as everybody knows. It's something he has said. We've noticed he'd said it in the past, but he's repeated it today, which was very interesting. That the NHS England Chief Executive, he told the board's meeting today that the STPs were here to stay, and the 5-year forward view delivery plan, due next month, would beef up the implementation capability which exists at STP level. He said the delivery plan will propose STPs are given decision rights, not only over many of our activities, but also the ability to recommend changes to the configuration of governments of constituent statutory organisations in those geographies where the STP believe that veto power or inertia is getting in the way of the bigger strategic change agenda which is required in that part of the country. Now, I'd like to know how everybody feels about having changes imposed upon them, that this exercise we're undergoing today is possibly, just in case, we might be considered to be inert. It could be, and if we are inert, it could be that the changes will be imposed from the top by NHS England, which I have to remind people is not a statutory body as such.
Okay. Would somebody from the panel like to just respond to that very, very briefly, if that's at all possible? I know it's a big question, but if you don't mind.
If those are things that Simon Stevens said today, I have to honestly admit I haven't had a chance to read them or think about them. I think, again, as I said in an answer to one of the questions, the Oxfordshire Transformation Programme, which is solely focusing on Oxfordshire, has Oxfordshire organisations involved in it, from health and the local authority, is thinking about and proposing to you and working with the public about the changes we think are needed for Oxfordshire. And that's what we want to continue to do. and that will be our share of the STP and is the way that we keep it local.
Okay, thank you. The table here.
So our table was worried about how, had some confusion about how this multiplicity of plans, so the Oxfordshire Consultation Plan, the STP, Bob, fit together and make it difficult to give an opinion on anything because it's not the complete picture.
Have I gone to every table now? Has everyone had a say? All right, thank you. Thank you very much. All the questions that you've asked, the most frequently asked questions will be answered on the website. As we said earlier, as Catherine mentioned earlier, this is not the only way to make your views known. Please do go onto the website, write in if you prefer to write in, email, make your views known. Thank you all very, very much for coming tonight.